Thank you very much for coming, Matt.
Yeah, thanks for having me.
Ah, it's great. We need some more exchange, you know. This is a good way.
Yes, yes, since we can't travel for a while.
Yes, of course. For me, everything went down to zero, you know, in like 2 days.
Yeah, yeah, I have canceled so many trips that were to take
Yes.
place. Yeah, I think it
Yes,
was,
for us, it's the same.
yeah, I think 2 weeks ago I was supposed to be teaching at the Cleveland Clinic.
Yes, and then after this, when this will end, we will have no time anymore.
Right, yeah, yeah, hopefully it'll get busy again soon.
Yeah, I hope. Here it looks like this. How's the situation over there?
So where I live in Idaho, we are on a stay-at-home order, so essential businesses can stay open. So the restaurants are closed, but grocery stores are open. Physical therapy can stay open. My clinic is open, but
Okay.
we only see maybe 60% of the number of people we were seeing before. I know some
Mm-hmm.
other physical therapy clinics are closed. Some doctors' offices are closed. Some are open, but they don't have as many people coming in.
Oh, okay. And the streets are very empty.
Um, there's still a lot of people driving around. We live on a green belt, so we see people going by all the time. And if we get a nice
Okay.
warm day, there's maybe too many people out running and biking. They're, just getting too close together.
Okay.
Yeah. How about over there? What is it like?
Oh, here's I'm just coming from the park with the children, and here's a lot of people outside too, but everybody keeps distance, you know. Everybody keeps like some people even like they keep like 4 meters. They're very afraid, even not if you say maybe they have high blood pressure or they have diabetes, I don't know. But a lot of people out here, but they keep all everybody keeps distance.
Yeah, and people are getting better here. I mean, it's a lot to change. People are changing their behavior so quickly, but we see people like couples walking side by side, and then they drop back to single file when they meet someone
Yeah.
else. So it's getting better.
It's, you know what I realized when I work in the clinic, I work with this mouthpiece, yeah, with, oh, how you call it, this,
A mask.
this mask, yes. And you are not, actually, you are not allowed anymore to touch yourself in the face, yes. And I
Yeah,
realized how many times I want to touch myself, yes.
yeah,
And I really have to hit my hand a lot of times.
yeah,
In the beginning, this was the worst for me, actually.
yeah. And then the more you think about it, then the more that you do really want to touch.
Yes, yes. And then you feel like, oh, it's itching so much. I
Yeah,
want to scratch myself. Yes. And I disinfect my hands. They are so dry now. Yes, unbelievable.
yeah. I've never
Yeah.
had my hands be so dry.
So I had a few questions for you because for us here, it was kind of a surprise, and I didn't quite get the decision because before you came, you know, there were only doctors doing FDM in the US. Yes.
Yes.
And
Yeah.
now you started to teach physiotherapists as well, yes, in the US. Is
Correct.
that
Yeah.
correct?
Yeah. Physical
Yes.
therapists can take FDM. It's been
Ah,
about
okay.
2 or 3 years that
Yes,
physical therapists can
I
take it.
saw this in between that somebody posted this. I don't know if it was the FDM Academy. And do you see now that the courses run better, that more people come to the courses?
Yeah, more people come to the courses, and it has been really, really nice to see just a variety of practitioners there. So you have medical doctors, you have osteopathic physicians, nurse practitioners, physician assistants, a physical therapists.
Okay.
We have athletic trainers and chiropractors as well that take the courses.
Ah, okay. Athletic trainers, they are allowed as well?
Yeah, because their scope of practice, they have the training sufficient to do that and be safe with the training as well. They can't
Ah,
do some of
okay.
the manipulation. So physical therapy assistants can also take the training, but they can't do the quick manipulation. But
Ah, okay.
they can learn the concepts and apply everything else besides the manipulation.
Ah, okay, very good. How came that? Did you press on the association that you said, okay, we need to integrate this, or was this a common ground that everybody said, you know, it's better if we have some more therapists and some more cooperation with everybody?
I would say that there was a lot of people looking at the situation, and there was a lot of change that was needing to happen for a while, it needed to be osteopaths really only to get the accreditation so that the continuing medical education credits could be given through the American Osteopathic Association. So once that was cleared, things have started to change a little bit. But I think as people see it, it works really, really well. And obviously it works well just with the way our healthcare system goes. Of sometimes our physicians here are too busy to be doing all of that. So they might see the patient and then refer them out for more. So like in my clinic, I have a lot of medical doctors and physician assistants, nurse practitioners that know FDM, but they might not have time to do all of it. So they see the patient, they recognize it'll be beneficial, and then they refer to physical therapy.
Okay. So you work together, physiotherapists and doctors in the same clinic?
Not in the same clinic, but just in the same town.
Okay.
Yeah.
So you have a corporation?
Yeah, so Therapeutic Associates Physical Therapy is where my clinic is. That's where my main business is, besides teaching with FDM Academy. That used to be once a month, and maybe next year again.
Yeah, we hope that. And when I see your courses, I cannot guess what kind of course is this. So do you have really courses only for physiotherapists, doctors, or they all come to you?
They all come together.
And you see they really mix, or are there some doctors maybe say, oh no?
Yes. So it's funny you say that. So when we've been at the medical school, we've noticed that it's like one side of the class is the medical students, and then one side is the physical therapist and the faculty, and the older doctors are in the middle.
Yes.
But we try to get people to mix, because it's really good to see the different styles and to see the different takes of what our background is. So we know different things based upon our medical or physical therapy education. Obviously, the FDM makes us all the same in how we do the techniques, but we have a different way of how we look at the patient from our original training. And in some of the classes I've taught, we actually haven't had any of the people tell what their background is. So we don't say who are the osteopaths and who are the physical therapists and who are the chiropractors. It's just, I'm Matt, this is Dave. And we go do the techniques, and then afterwards, because sometimes there's some bias against other professions, but it's nice to just be an FDM practitioner.
Yes, it's the same here in Europe too, actually. We have, when we have courses here in Germany from one organizer, we have really, really big courses. And we have about 50, 60 people. I see you have a big courses too, yes? You have a lot of participants.
Yeah, there's been some really big ones, yeah.
Yes, I saw this. It was very impressive. Big rooms, a lot of tables, yes. And we recognized over the years, Georg told me this actually. George said, did you realize I make longer breaks in the module 3? I said, yes, I realized this. Why you do this? He said, because all the doctors, all the physiotherapists, the osteopaths, they start to get in contact and talk. And you see, they always come later back from the break. So he makes bigger breaks or longer breaks in the module 3, and this makes sense.
Yeah,
and you can do it.
There's a lot of networking, and you start to learn how you can refer, and it's helped my practice as a physical therapist, just knowing more doctors that do FDM. If I have a patient that has a suspected fracture, then I know more physicians that I could refer that patient to, to get the care that they need.
Yes. Yeah, that's very good. And how do you think you will do this after the courses? Will they organize themselves some work groups, or how will you stay in contact?
So we've been thinking about that recently, and I could move to more online, but I think this could be good anyway. Of the advanced course that we were thinking of doing this July, I don't think that that's going to happen, but maybe we can video record all of the pieces to it and put them together so that anyone can see it from anywhere in the world, because there's only a certain number of people that might have come to Boise in July anyway. We were expecting maybe a 40-person class, but maybe we could have 400 people that end up getting all the material that we were going to do.
Yeah. And do you have a concept? Because lately, I tell you, I saw now, for example, one student of mine in Switzerland. She had a tier. They have a lot of skiing in Switzerland, yes. And as you have too, I think, yes.
Yeah.
We don't have so much in Germany. It's very, very. We have no hills here actually. And she had a tear of her knee, and then she went to different therapists in Switzerland, and it were students who were there in the beginning who do FDM for a long time, but actually the treatments weren't so good. You know, after all those years, they lost a little bit the contact, they lost the consequence and everything, yes?
Mm-hmm.
And you see, greeting from Tehran, Afshin, hi. And so that's already what I think now about, you know, everybody, we have, I don't know how many courses you have. You have the same modules as we have, like 4 modules.
Yeah, we have module 1, 2, 3.
And then you actually lose everybody, you know, they're just back in their clinic, and some go to work groups, some not. So I'm thinking about, and a lot of people come to my clinic for hospitation, but it's only 1 day or 2 days. It's nice. They come from Russia, from Switzerland. But actually, I would think we have to do more to stay in contact, you know, to have this exchange still. Do you have an idea on this?
I haven't thought of that, but I've definitely seen that where people fall off. So when we see people go to a course and, you know, they think, oh, I've learned FDM. I know FDM.
Yeah.
And then 2 years later, you know, I get a patient that had seen them and there was no FDM going on. Like maybe they still did a trigger band, but that was it.
Yeah, that's it. And but this isn't so big already, you know, because I think here we have already a lot of therapists, and now it starts coming to me more and more that people go there and tell me, oh, I already had FDM, and then I ask them what the guy did, and it doesn't sound like FDM anymore. Yeah.
Right.
So I'm thinking this is a problem that is occurring here now, that I'm thinking, what can we do? You know, what can we do for this, that the quality stays better of the therapy? Yes.
Yes. Yeah, I think that'd be really good. Yeah, we've done study groups. We do them every 2 months usually.
Okay, you're doing it. Study groups.
Yeah, we call it a study group. So every 2 months we come together for 2 hours, and the format is widely variable depending on what people want. But we think of, you know, what are the difficult cases that we're seeing? And we might just talk about it. Sometimes we bring in a patient. We definitely do techniques. So people want to do the foldings a lot and practice.
Okay, yeah.
And at the end, then we just start working on each other and fix all the things that we have going on.
Yeah, that's very good. So you're doing this in Boise, or you're doing it in different cities?
I do it in Boise. Yeah.
In Boise, okay.
But in the classes, I encourage people, you know, like if we're in a bigger area, that they should get together as a group and start to do those.
Yeah, and you see, they keep doing this, or they need some force from outside?
They usually just need, like what we call a cheerleader. They need someone that's really excited about doing that to keep the momentum going for a group locally.
Yes. Yeah, I think that's a good idea. But the more seminars you will give, the more it will come. Yes. Oh, here, Mark, he commented. He has a study group. Yes.
I was thinking that Mark would probably have one. Yes. Good job, Mark.
Yeah. Yes, very good. I saw the photos from this one.
Yeah. So I was thinking, for the people that don't know FDM, how do you describe FDM to people that don't understand what it is?
Oh, that's a good question. I would say we are explaining the whole world, or all complaints we explain by fascial distortions, reversible or reverse fascial distortions. And the special thing about what we do is that we that the objective findings are not the highest, you know, the highest factor or the most important factor for us. Hold on a second, my son is just coming.
Okay.
One second.
So I'll explain my version of it. When people ask me what it is, like you know, a physical therapist or a doctor, then I say you really watch the patterns of how a patient describes their symptoms with their hands. So, you know, a patient says it hurts right here. That's different than if they say it hurts right here, or it's here, or it's here, or it's kind of in here. I don't know what it is. And all these gestures mean something different. And it's been very interesting to me to see how people can be very reactive hearing about fascial distortion model. They get really pushed back by, oh, it's fascia. Oh, I don't want to work with fascia, or they have some other preconceived notion. And it's really just pattern recognition, that patients show you these things. They intuitively know what needs to go on to make it better. And they're showing you a technique. They're showing you how to make it better right away. So one of my interns come in and they start going through all their orthopedic tests. I'm like, this is great. You can do all these tests. Now, what are you going to do? What's the diagnosis? What's the prognosis? And, you know, their idea of what's going to go on, like this might take many months to get better with traditional therapy. And I said, well, let's try some FDM. And 5 minutes later, it's all better.
Yes, that's a good explanation. Yes, what it is really. Yeah. How did you get to FDM? How did you find your way?
So that's a funny story. So there was an osteopath here in Boise, and he gave me a link to the book from Dr. Typaldos, and he said, "Here, read this. It's really interesting." And I read the fourth edition, and it made, you know, about this much sense to me. I kind of got it that there was some hand gestures, and it was about fascia. And he, I was trying to meet with this doctor to talk about myofascial release, and I was trying to schedule a lunch with him. And his office was saying, the doctor wants to know if you read the book. And I knew him really well. This is going to be a test. I was going to go there and get tested on what I knew from the book. And I didn't think I knew enough. And so I delayed and delayed. And 6 months went by. And he calls up out of the blue and says, sorry about the short notice, but you have to get to Washington next weekend for a class. They're bringing the only doctor in the U.S. certified to teach this, and you have to go. And he had really pulled some strings so that I could go to the course, because they weren't really letting physical therapists in at the time. There was Marge Caston. There was Lex Gillian from Texas that he'd gone to do some stuff with Marge. So Lex and I went to that first class, and it was 10 years ago this fall in Yakima, Washington at the medical school there. I got in, and everything was different.
Okay.
Yeah.
But who was the teacher? Who was the teacher?
That was Byron Perkins.
Ah, okay.
Yeah. And I remember, I very distinctly remember his case study about someone that had a fibular fracture, and they were running on it by the second visit. And my first visit back in the clinic called up, and they had run a marathon on the weekend. And they called up Monday morning, and they said, I have this deep toothache-like pain in the bone, this deep pain in my tibia, and it's really, really sharp and hurts like a toothache. Should I go to the doctor and get put into a walking boot, or should I come in? And my orthopedic mind said, that sounds like a stress fracture. And I was remembering, oh yeah, she's being treated for low bone density. This is very likely a stress fracture. And I was thinking, go to the doctor. That would be a good idea. And I thought, oh, stay in the model. Why don't you come in and show us what you have? She comes in, limps in, and she points right at the bone. And I said, okay, well, what else do you have? And then she started showing like up and down in the muscles. She showed trigger bands. She showed HTPs. And I said, okay, I'll work on those. I'm not going to touch the bone. I'll work on all the stuff you feel around it. We work through it, and it's getting better and better. And about halfway through the visit, now she's walking and she has no pain. And she says, you know, I have another marathon coming up this weekend. Do you think I can do that one too? And I was just like, oh, like that is so crazy. You very likely have a stress fracture and you want to run another marathon. So I thought, I'll be able to talk some sense into her. So I thought, you know, well, keep coming back this week. Let's keep working on it. We'll see you 3 times before this weekend trip you have. And she walks out of the clinic, and we watch her through the front window. We see her in the parking lot, and she has someone to come pick her up, and she's doing jumping jacks in the parking lot, showing off how good she feels. So we see her Monday, Wednesday, Thursday, and she has no pain by Thursday. Like, she can do everything. It's not hurting. And we made this agreement. I said, if you go do this marathon, if you have a stress fracture, that's a really good way to get a full fracture. But if you have no pain, and if you take nothing for pain to diminish it, you can run as far as you want, take a phone with you, and sit down when you start having pain and call for a ride. I thought this was a fair way to go about it. So she comes back after that weekend, the following Monday. So now it's been 8 days since the first marathon. And she says, well, I ran the whole marathon, and now I'm just a little bit sore in both my calf muscles. I'm like, but of course you're sore, but like, that's incredible. You just ran a marathon, what was probably a stress fracture. So that completely changed everything in my practice from that point forward, to be able to do that to somebody and get them back to that level of function. And it was safe.
Okay.
Yeah.
Wait, which year was it?
So that would have been in the year 2010.
Oh, 2010 already. Okay.
Yeah. Yeah, that was my first year in FDM.
Okay. And then how long did it take you to visit the other seminars?
So I started going to every seminar they were holding. So it's about every 6 months. And some were just a repeat of the same module 1 over and over again. But I kept learning
You went
more.
to one like several times.
I did it a lot. So when people go to the classes and they say, I'm not getting this, I'm like, well, I didn't get some of this until my 4th or 5th time through it. But as you go back to your clinic and you see more patients, then you have more depth. You come back to a class and you're like, oh, now I get that.
Okay.
Yeah.
Oh, that's the first time. This is great. Yes, well, because for me it was same. In the first seminar, I understood HTP, TBCD. Cylinder, tectonic folding, I just missed it. It was too much.
Yeah. And every time I
that,
teach, I still learn something. Somebody in the class will have a comment, a question, and it just gives more clarity and more depth to the model.
Yes, exactly. Oh, that's the first time I hear this. That's very good.
Yeah.
And then how was your way to the instructor? Did you become assistant in the courses, or?
Yeah, I was an assistant to Dr. Capistrant for many classes, maybe a pain in his butt for many classes, but I'd raise my hand a lot, and I'd either have questions or just offer some other insight, maybe from a physical therapy perspective on how we might go about the patient a little bit differently. But we've learned from each other that way, and it's just given us more awareness of all the professions.
Okay.
Yeah. I see some questions down here.
Yes. Is efficiency of FDM and mechanism like acupuncture? You want to answer this one, Matt?
So acupuncture, you're manipulating the fascia with a needle. There's a lot of different theories about what could be going on. You're also going to be stimulating the nervous system. I have a therapist in my clinic that he does dry needling. So it's using the same tool as acupuncture, just a different thought process, but he also does FDM. So when he applies the needling, it is with an FDM thought process, thinking about what specific tissue he's going to target. So like for a herniated trigger point, you might be needling right around the edge of it to loosen it up so that herniated trigger point can be reduced. But there's so much more that FDM does beyond just that little bit with what a needle can do, I would say. How would you answer that?
Yes, it's a good answer. I would say it's, if you use a needle, it's always the same force on the tissue. And we do different forces. We press, we pull, we use the whole hand, we use the string. It's a kind of more a different kinds of intensity we have on the tissue.
Yeah. I think I was going to say there's sometimes I feel like there's some depth that the needle can get that I can't get to because the force is so blunt. So if say we push down to the lamina on the spine, that by the time you get through all that tissue, the force is pretty spread out. And sometimes that needle, I think, is nicer. So like getting the continuum distortion way down on the bone, if you could do that with a needle, that would be a really good CD. So the physicians that I refer to for like for prolotherapy, one of them, he actually like dents the tip of his needle. Like he flattens the tip of the needle. He pushes so hard under the bone. And I say, oh, you're doing CDs with your needle tip.
Okay.
Yeah.
Yes, this is already also a second step. If the fascial distortion model is really so good, then we should explain all the effects that chiropractic, craniosacral therapy, orthopedics have. We should explain it from our point of view too, or we should be able to explain it. Yes.
Yes, that's what I think. A good model should be able to incorporate those things.
Exactly, but this is one I have to say I'm lacking of this. My creativity is nearly zero. I know about what I'm strong, what I'm weak. In this part, I'm very weak.
Yeah.
This is also, when you have the exchange on the seminars, you have sometimes participants or students. They have very good ideas. They are very creative, and this exchange is very, very important.
Yeah.
When we say acupuncture release fascia in target points and other region like FDM?
I would say sometimes. I mean, it can be a good complement. It works sometimes by different mechanisms, but you can definitely blend it in with FDM. I've heard of some people say that when they use the needles like acupuncture or dry needling, that it can help with a stubborn HTP, that maybe they can release that easier. make it easier on the patient and the therapist if they do that first.
Mm-hmm.
Yes, I'm
yes.
not trained in the dry needling, so I don't have personal experience with it, but from the people that have talked to me that do FDM and needling, that's one of the things I've heard.
Do a lot of people do dry needling in the US?
Idaho just got the ability to do it last year. So there's a lot of, for physical therapists, so a lot are doing it now.
Oh, okay.
Yeah, state by state, there's many states now that physical therapists can do it, physicians can do like a medical acupuncture. So there are quite a few that do that. And then I know a lot of physicians in the area that were already doing injections, and they just do it slightly different once they learn FDM, thinking about what they're trying to target. So it's not just getting the fluid in with the injection, but what they can actually do with the needle and how they're manipulating it, that would manipulate the fascia as well.
Okay. So the thinking just changes, yes?
Yes. Yeah, I saw that one time. I got to go watch a surgery, and actually it was for a herniation of fatty tissue on the back. And what we thought was about maybe that big, and we just could not get it down. We could get it smaller, and it just would not go away. So the patient got into surgery, and the surgeon found it, and we could see like, oh, there's the adipose tissue. And then he digs in deeper, and then we see that there's more and more and more. And it ended up being about the size of a racquetball that was taken off of the sacrum. And he closed all that up. But afterwards, he said he found an article about this whole idea, and me talking about FDM during the surgery, it changed his way of doing the surgical techniques. So from then on, he tried to, when he can just get down to a good layer of fascia that he can close up, that's the deepest that he will dig. He won't dig down all the way. He just finds a really good layer to get good closure, because he doesn't want to have anything open up and more tissue coming through. So I thought it was interesting, just like 45 minutes in the surgery, well, probably an hour and a half in the surgery, talking to him, he changed his thinking without even going to a class. Just the ideas made sense. And I never thought as a physical therapist I'd be changing a surgeon's technique. But it's a really cool thing about the model is it can do that.
Yes, that's it. Actually, there's another question. It's Afshin. He's from Tehran, but he lived long time in Canada. Hi guys, for me, when I'm trying to fix the ICD for continuum distortion, but then it ends up his question. Do you see it?
Yeah, I see it. So is that with needling? Needling, trying to fix the CD?
Yeah, I think Afshin, he's doing also needling, yes?
Yes. And that would make sense. So for those that don't know FDM that are following this, like the CD being like a little tiny spicula bone sticking up that the needle then could be trying to push it back down in.
Yeah. Do you have some comments for doing, what is it? BETTE, what is it?
For doing it better?
For doing better. Okay, to fix the inverted type of continuum distortion.
Right.
Yes, very difficult. Most difficult topic for me, CD, in the daily clinic.
Yeah, the inverted CD, you mean, is the difficult one?
Actually, every type of CD, I have to be honest. In the beginning, it was so easy. I had such good results. I have the feeling now I started my first course in 2006. Now I'm even worse than 2006, you know. I had more success, or felt success by 2006.
So maybe you're just more critical now.
Maybe, yes, but I have so many complicated elbows.
Mm-hmm. Yeah.
They have many CDs inverted. How's for you?
I don't sense that there's a lot of inverted CDs. I have seen them occasionally where it's almost like process of elimination. When I teach it, I say it's like seeing a black hole. How many black holes have we seen? We know from data that around it, like there's something there, but you can't really see it. That's how I think that it is with this inverted CDs. You usually don't feel it, but you know that it's there because it acts like a CD. You just can't push it in.
That's it, yes.
I always find some way to get a pull into that area. So if this is the inverted CD, you have to figure out what tissue is that and just get some torque and tension so you can pop it back out.
Mhm.
And so I usually have to go back to thinking of like anatomy and kinesiology on what tissue is that, and some of it is just by feel. That if you can
Mhm.
push on it and you feel that area, you'd wind up tissue until you can feel like you can get it right to that spot to be able to pull on it.
Yes, from I on the elbow, I saw the Japanese guys, you know, Kesketanaka, and they just took the tissue and just pulled it up in different direction, and I just pulled it, but they did it for a longer time in a different direction, and I saw this help sometimes too.
Yeah, and that makes sense that you have to get different angles to get that to pull out.
Yes, but as you see, it's difficult for us too, Afshin.
Yeah,
It never ends the learning. That's maybe why we do this job, because the challenges are always there.
correct.
And we have to take the patient's face when, and is it better? No. I
Yeah,
think it's same. To press on the spot again.
yeah, yeah.
Yeah.
And for people that are skeptics of FDM, I think, they need to watch this being done, because when you do a technique
Yes.
and you think you've got it and the patient says, nope, no better.
Yeah.
You do it again,
That's it.
nope, no better. And then, yes, that was it. Like, there's a little piece of evidence right there that I could think it was being right. A patient could have been wanting it to be better, and we could think there's placebo effect, and they say, no, no, yes.
Yeah. Yes. And do you treat patients too in your seminars?
Yeah, so we bring in patients from the outside to treat in the seminars, and then we get volunteers from the class as well.
Okay, yeah, that's good. Because actually, I studied 5 years osteopathy, and none of my teachers did this. And when I visited my first seminar of FDM, he treated like 2 or 3 guys, George, yes?
Mm-hmm.
Real patients from outside, which whom he did not know. This was very new to me, that somebody treats live in a seminar.
Yeah.
I don't know. Yeah. And this is what I see today. It's the biggest stress for me in front of the class to treat somebody and to have a success. Now it's becoming easier after the years, but it's the biggest stress, but it also changes the atmosphere so that you not only talk and show technique, but you show really what it can do.
Yeah. Yeah.
Yeah.
It's really, really helpful to see that, because you have an expectation, like, therapy, like, oh, this might take 4 weeks to change. And then you see it change overnight.
Yes, exactly. Yes, yes.
Like we had one patient at the Cleveland Clinic. I remember very well. They brought in somebody that had had pain in their hamstrings for 18 years, pain in the thigh, and they had weakness there. So they'd been given therapy over the years, and it was always hamstring strengthening, hamstring strengthening. And we thought, if you've been doing hamstring strengthening for 18 years, why is it not, like this big? And it was just one HTP, you pop it in, and all of a sudden now the strength is 5 out of 5. That was amazing to see, because you just don't expect that with traditional treatment.
Yes. That's my colleague from Russia, Evgeny. He just told me a very good thing, because he made an interview here on Instagram with a dentist, and I told him, why you make interview with a dentist? And he said, I think the approach is the same for dentists, because there was a dentist in Russia. It was our first course in Russia, and I told Evgeny, why is a dentist here in our course? This still never happened in Germany. Why in Russia dentists come to our course? And to module 2, he showed patient videos of the ankle. I told him, a dentist ankle, what is happening here? And he told me, because his approach is the same. Because, for example, he told me, if you have a shoulder pain, here, the osteopath will tell you, it's because of your liver, and drink less red wine because the liver hangs and pulls on some anatomic structure or whatever. And he told me, but still you can think about this, but still there's a shoulder. And he
Yeah,
said, for the dentist, it's the same. You can tell somebody, maybe don't drink Coca-Cola and you will have no holes in your teeth, but you still have to fix the tooth,
right,
Yeah.
right.
So for them, it's very clear. And I said, oh, that's a good idea, yes? So the
Yeah,
approach came. Yeah.
yeah.
So
We had a
did you
class.
mean there? Yes.
We
Go
had a
ahead with
class.
the visceral.
Yeah, we were talking about CDs in a class, and I would mention I learned more about CDs from one of my patients who was a dentist, and he talked about finding these little spicules of bone underneath the gums, and how he was taught as a dentist to push them in or to knock them off and smooth them down. So he'd mentioned that, and I had another person lecturing while I was in the back, and they were assisting me. So in the back, one of the class participants turned to me and says, "Do you think that would hurt or help for my tooth? I have this tooth pain right here." I was like, "Well, you're pointing it with one finger. What is it?" She said, "Well, it would be a CD." So I just pushed right there, and it got a little better. We did a little bit more, and she says, "I need something to test. I need something crunchy." And she went and found someone's peanuts or something and started crunching. She says, "Oh, now it's right here." And she did that one finger. So I found a glove, put a glove on, and the strangest thing to me was that I could feel where the CD was on the tooth. It wasn't raised up. It was just harder than the rest of the tooth. And I said, "Is that it?" And she goes, "Uh-huh." And we pushed through it, and we got most of the pain to go away. She had been going to the dentist, and they thought the next thing was going to be having a root canal done. And that was going to cost $1,500. And it was some CDs in the tooth. She didn't have to go get it done.
Oh, you see the question there from Dr. Kudelia. He's from Russia. He's treating a lot of MMA guys. So you just answered his question, yes?
Yeah, that can work for some tooth pain. Yeah, I haven't had a lot of experience, but I'd say for all the tooth pain that I've treated, I've been 100%. Maybe two people, maybe. Yeah.
Oh, there's the question. That's Giannis. He's from Greece. Hi, Giannis. How do you know that patients show a dermatome instead of trigger band, let's say? Or you mean when they have if they have a disc hernia or trigger band?
Mm.
We never know. Yes, the body language is the same. I think I can answer this. I think FDM treatment is more true than an MRI, because you cannot see on the MRI it's really the disc hernia or the trigger band. You know, if they have no pushing pain, I think the body language is still the same. Yes, Matt, you would say the same?
I would say the same.
Like, for example, some patients do like this and then they have this radiation, yes?
Yeah. And I'd say it's dermatome. Like if you keep treating and it's not getting better, that's coming from, you know, something more central. That could be from the disc. But you could have a disc herniation that's causing problems, and you could have a secondary trigger band as well. And you treat and see if it gets better. If it doesn't get better, then you go back and reassess.
That's what you cannot see on the MRI, yes?
Right.
Yeah, that's what you only can see by treatment, yes. But I have some patients too, it doesn't work, and then you can say already in the first treatment, no. I think already I had now some patients who had this, you know, and their fingers, they had a little numbness, and they had no pushing pain, like in a normal trigger band.
Yeah.
Yeah. I think it's the same with the AACD, you know, with foot drop.
Right.
Yeah.
The anterior ankle CD. Yeah, I think it can cause those issues, and maybe there's true foot drop issues that need to be addressed neurologically, and sometimes it's just a CD. So you try the easy treatment first, and then you reassess and see if it worked or not.
Yes, exactly. Yeah. Then that's a question for Mahmoud. He's from Mashhad. It's right from Tehran, and he did his first study in Iran on FDM. I'm very happy about this.
That's very good.
I have to say, Mahmoud read an article from Georg, like, I don't know, 3-4 years ago, and he waited until 2018. He waited 3-4 years just for his first FDM seminar. And then last time he came to a work group just for 3 hours, he traveled 10 hours by train, yes? Mahmoud is really giving effort on this. And he has a question. You see this, Matt? Can you read it?
Yeah, some resources for the differentiators, neuropathic versus nociceptive pain. Is that a statement or a question, Mahmoud?
Mahmoud is always writing so slow. I press on him already that he starts to write faster. I think it's more an answer, yes?
Yeah.
More an answer. Yeah. There was this question about viscera, if we can also treat visceral. I would say everywhere where's Fascia? Ah, it's an answer. Yes. Okay.
Yeah.
Everywhere where's fascia, there can be a distortion. Yes.
Yeah. Anytime there's fascia, anytime there's nerves involved, which they're everywhere. I mean, we have nociception then.
Yes. And then, so everywhere where's tissue, something can distort and we can treat.
Mm-hmm.
Georg has always this joke in his seminars. He said, show me a manual therapy clinic or a manual medicine clinic where there is guaranteed fascia-free treatment, you know. That's always his joke in the module 1, and it's so true. Yeah.
Right.
Everybody says he worked on the muscles or on the nerves, and who knows? Yes, there was always tissue in between. Yeah.
Right. I mean, even when you exercise, how do you stop the fascia from being moved, have pressure on it?
Yes.
And all the
there's
nerve
another.
endings. Yeah.
There's another question from Giannis from Greece. FDM is a functional or structural approach. You want to answer this one, Matt?
I'll say yes, it's functional or structural, because you're going to be addressing both. I try to address the function and how patients are moving. So I think structurally, but I'm also having them move functionally. So like, show me what bothers you. Show me what you can't do. Show me how you get there, what it feels like. So we address the function that way, and then we get to the structure with what they show in their hand gesture. Then we treat the FDM distortion, then we make it better. So then the function gets better. So I'd say it's both. You should be treating both.
Mm-hmm. Yes, that's good answer. Yes, I would think the same. Yeah, I think really something would change in the body. But so far, I got the question last time from Mahmoud. He asked me, are there some studies about the FDM? And I said, we have some clinical studies, of course, yes, about the shoulder study, forearm, anterior cruciate ligament.
Yeah.
But actually, we have no studies proving the distortions, yes, to making them an objective finding to see it on X-ray or whatever, yes?
Yeah.
Or is there any? I don't know any so far.
There's not really where they're looking at the structure within the body so much and trying to put that together with the FDM. I think it's more clinical studies on, is there an outcome? I mean, like the German one on back pain, I think was a good study to start with on comparing FDM to traditional treatment.
Yes, that's what we have so far. Yes, we concentrate more on clinical studies. Yes.
Yes. Yeah. I was thinking about the model this morning, because of all the models that are out there about COVID-19 and, trying to predict where things go. And you can see what happens with a model in its infancy, that the models are not very good. They get better over time as you add more data. And so you can think back to what we know about Dr. Typaldos, and he started with one thing. He started with just the trigger band, just showing that line. And then it advanced from there, and he added more and more to it, and it gets better over time. So now I feel like we have a model that works really well. I can throw a new problem at it, and the model spits out an answer, tells me what I should expect.
Yes, exactly. What I see now, I think it's a little bit a different situation here, because we had already so many courses. We have already a second and third generation of therapists. We saw this when we go to Russia. In the first generation who come to seminars are like the people who are always searching for something. They are never happy. They always want to have something new. These are the guys who buy the first generation of iPhone, who has all the children diseases,
Yeah.
And they come first. They will not stay. They will move further anyway. And now we have the third or fourth generation. It's like those people would never go to something new. They're very afraid. They only go when everybody goes.
Right.
And what I see in those people actually now is because they have a different mentality, a different character. And one crazy thing is really what I talked to George about this. I told him, George, it started last year that I showed the technique on the left arm, and somebody asked me, but how does it work on the right arm? It started last year, yes?
Yeah. Yeah.
And then the other thing is about those people, because they want to have something safe already, and they found the truth already. Then they try to put the FDM in the old models, and this doesn't work.
Right.
Yes.
Yeah. And I've seen something interesting, having gone to the medical school in Yakima, Washington, where I learned it, and I did many, many courses afterwards. I saw many people coming through the medical school where they came in as a patient in their first year. And then the second year, they're in the class. And then the third year, they're taking another module. And the fourth year, they're taking another module. And then I've seen some of them out on their rotations and their residency, and they just think that everything makes sense within FDM. You know, all the other stuff fits into FDM first. So they just completely use everything with FDM. I saw this with a physical therapy student as well, that he was the first to start taking classes in FDM as a physical therapy student, and he took all of them in his years in PT school. He was great at it. He came into one of our classes recently, and he brought in a soccer player, asked to treat them in front of the class, treated it perfectly, and even had one thing that didn't work. He talked through all of his thought process on what he needed to do differently, but was able to do all this. And to him, that was just like, well, everyone should be able to do this. This is just how it works. It's brought up completely in FDM.
Yes, yes. And this is a different kind of thinking, and we have kind of a different struggle here now. Yeah, because the people try to put this in their old mind. We say, no. You have to allow yourself to think for yourself,
Yeah.
to use new model, but not to put it into what you know already.
Yeah.
It's kind of difficult.
Yeah, we try to get that, and I've found people that have been out as a practitioner for a long time, it can be more challenging because their orthopedic is so big, and they try to put everything into orthopedics. And I say, no, set your orthopedics aside.
Yeah.
Here's FDM, here's your orthopedics, bring them apart for a little while. After you learn them really well, then you can blend them together and see how they work together. It's a Venn diagram. It overlaps about 90%, but you can't learn it by thinking of your old way first. And I always say it's like learning a foreign language. You don't try to translate everything back. If I'm trying to learn German, I don't try to translate to English. Like, it's best to learn German. And I think the same way for FDM is like, learn it the new way first. It's going to be hard, and then later, then you can translate back.
Yes, that's it. Yeah. And I wanted to ask you something, Matt. I saw this project that you have in Belize. Do I spell it correct?
Yes, in Belize, yes.
Yes. And how did this come up? How did you make this up? How did you get the contact there?
So I have to give credit to Dr. Perkins, who's been doing the outreach in Africa, and I got to go with him once to Burkina Faso, and I wanted to do more things like that. So I started looking for a place that I could go to, and I went to a big National Physical Therapy Association conference, and they had information about global projects like this and global service learning. And they said, find a good group that's already established and it has a good reputation. Don't try to invent things up on your own. Like, go with someone else. It's better to pay them and do that. So we found a group that had Central America, and I looked at all the countries that they had, and I was looking for a country where it was going to be very stable, that they can go back to year after year, and wasn't going to be sometimes changing. So Belize really fit the bill on being very stable, very needy. And they had a good set of contacts already there. So we did it last year in 2019 and had a small group of Belizean physicians. We went back this year, and those early physicians, they helped recruit new ones for this next year. And they found some really, really good doctors down in Belize to be doing this. That just blew me away. I mean, it fills you up on the inside to see this. When they're learning FDM and like just immediately putting it to use, some of these doctors had to go to the hospital and cover a night shift while we were teaching class. So they come back the next day and they said, I saw patients at the hospital. One of my favorite ones was all the patients are asked for Tylenol. One of the doctors was being asked for Tylenol for a patient with headaches. And they said, I've got these headaches, and can you give me Tylenol? He says, no, I've got this new drug for you. It's called Handinol. I'm going to put my hands on your head, and it's going to help you. So it's called Handinol instead of Tylenol. And it's so incredible seeing that. So we're excited. We hope we're going to be able to go back, that the coronavirus things will get better. We can go back next year. But we will continue to teach there and get more doctors in. What's really exciting is that they're able to track their outcomes there. So they're going to start tracking how many medications they're using for their patients. So they can see the doctors that have learned FDM and compare them to the doctors that don't know FDM and see how much they're prescribing medications. and then we can start
Cool.
tracking before and after. So they're going to be developing some data there.
Oh, cool. That's good.
Yeah.
Great. Yes.
Didi?
Oh, we have some questions there. You saw it? We had one question if we also give some exercises. If we do your work on patients just with FDM, what about giving exercises, or what about preventing recurrences? How do you answer this, Matt?
So exercises, I think, are great. I get a little bit spoiled with my patients that I have a lot of patients that are very active naturally. So they have something that's limiting them and they want to get back to doing it. So sometimes I can just say, all right, now that it feels better, let's get you back into your exercise routine. And they already have something going on. Other patients, they need more of a boost. So we do give some exercises to get them moving better. Obviously, it helps the healing process to be doing certain exercises. And for preventing recurrences, then it's looking, I'd say sometimes then that's where I start to think more like my physical therapy training of what's driving this problem. Why do they keep having this thing coming up? And maybe it's something above or below that's driving this problem. Then we need to go find that problem and help fix it.
Mm. And that would answer the next question by Monica. She visited the FDM course in Poznan in Poland.
Yeah.
And she asked, what do you say to your patients if they ask you for a diagnosis?
Yeah.
They usually expect clear answer with typical disease. I don't know, Monica, if they expect always typical disease. You could say, did you feel this heartstring that you told me about, or this spot that always bothers you? And then it's answer enough, I think, normally. You know, if you put it back to the feeling of the patient, I think. Would you say the same?
Yes. And now more research talking about pain science, it makes sense that if we give them a diagnosis in the medical system, that can actually be a bit scary. So even talking about how FDM would describe it, saying someone has torn fascia, that could scare somebody. But if I say you have some tight stuff going on here and we're going to make it loose again, they're like, oh, okay. And most people are very happy with that. They just want to get better. And often they don't care about the diagnosis. And then I have some patients that are kind of complete opposite. They have an engineering type of mind and they really need to know structurally. And I remember this one patient very clearly. He came in and he said he's a triathlete. And he said, I can't do this. It hurts up here. And I'm thinking, why do you have to internally rotate and come up? That makes no sense as a triathlete, but this was very important to him. So we work on it and it's better by the end of the first session. He comes back second session. How are you doing? He's like, oh, I don't know. Not so good. And I'm thinking, it's better. Like, what's the problem here? And he said, I think I need to go to another doctor, maybe an orthopedic doctor. I think I need to get an MRI and really find out what's going on. I'm like, oh, he doesn't believe me. He thinks I don't know anything because I said he has some tight stuff here.
Yes.
He's like, what do you do for a living? He's like, engineer. I'm like, oh, okay. So there's a little tear here in this ligament and this, and then after a few minutes, he's like, oh yeah, it's definitely better. It was the same, but he needed to know a diagnosis. But most people, they don't care.
Yes, exactly. That's it. I had already some engineers, they don't even show on their body. They bring me a drawing. They painted a human on a paper and they draw all the trigger bands on the paper, because they were so intellectual.
Yeah. I think those people, they need a really good diagnosis.
Yes, and we could give it to them as well. Yes.
Yeah, they need very structural.
Yes. But I think most patients are not like this.
Right.
Yeah. So back to Belize. So you will be going probably next year. This year will nothing probably happen. Yes.
Yeah, we already did our trip in, what was it? It was in February that we did our trip. So we got done just in time before things got really bad. So we were thinking of going back in January. We'll just have to see how things are going later in the summer and fall to see if it looks like we can go back. But we'll be going back for sure. And so we took a team of 8 people from the U.S. to help train down there. So our people from the U.S. were able to, then we could do more like one-on-one, hands-on, that our people from the U.S. already had FDM training. So it made it a lot faster with the physicians there. We could get through the material a lot faster. And then we did treatment days for all the people in the community. So last year in 2019, we treated 100 people, and this year we treated 250 people in the community. So we did the module, and then we just had people come in, and we would divide into little groups. So we'd have usually like one physician from Belize and one person from the US as a team, and then they would treat the patients together, and I would circulate around and just help people with any problems. But we got through a lot of patients, and I'd say we were probably having like 95% success rate on making improvements in that amount of time.
But this is very good. You go with 8 people from the US there.
Yes, and so that allows us to treat more people and allows the seminar to go faster because they get more hands-on, and there's just different ways of looking at it. And we had myself as a physical therapist, an occupational therapist, my wife, a nurse practitioner, osteopathic physicians from the US, and then it was all medical doctors in Belize. But it gave a wide variety of thought process. So it's working really well. We really love the format and anxious to go back.
8 people, that's a very big group. Because, you know, from the photos I saw, you made some travel, and I saw the group, and I saw there was a big hall. Matt, can I call you back? Because this only lasts 1 hour on Instagram. Can I call you back just now? Because it will finish by itself then.
Yes.
Yes? Okay. I'll just end this and call you back in a second.